Well, hello, my name is Justin Fraser. I am the Vice Chair of Neurosurgery at University of Kentucky Hospital. And I wanted to thank the CNS Education Committee for the opportunity to participate in this great program. And thank you for joining us on the Neurosurgery 100. Today, we're going to be talking about unruptured brain aneurysms. These are my disclosures. I don't have anything that's relevant to today's talk. What we're talking about, again, is unruptured intracranial aneurysms. And it's estimated that the prevalence in the adult population is between about 3 and 5%, which means that up to about 1 in 20 adults will have a brain aneurysm. It's a relatively even sex distribution. And when you look at subarachnoid hemorrhage, which we all manage, it only occupies about 30,000 people per year. And so conservatively, the penetrance of subarachnoid in the population is less than 0.015%, meaning most aneurysms don't rupture. So the issue that we have is, what is the risk, okay? And for many patients, they have no symptoms when it comes to actually having the unruptured aneurysm. And so it's the most feared issue is rupture because it's so spontaneous and without warning oftentimes. So when we look at prior papers that have tried to estimate the risk of rupture, we can go all the way back to papers, even the early 2000s, that looked at annual incidence of rupture. And so when we look at the earlier papers, they seem to show us that rupture risk can be as high as about 1.3% in general. But then those cumulative rates go up with time. So the more number of years you're exposed to that risk, the overall risk goes up, as you can see there. So there have been some longitudinal studies trying to estimate rupture risk. And there was a South Korea study that looked at almost 6,000 patients, and they estimated that the annual risk of rupture in the overall population was about 0.9%. Another Japanese study, again, looking at about 2,000 patients, estimated that the annualized risk was about 0.76%. So small on a yearly basis. All of us are aware of the Ishua study. And really, this was a landmark paper to look at aneurysm size. It showed that amongst different groups of risk, the risk varied significantly when you take into account size and location, as shown below. And so 7 millimeters really became kind of a cutoff point, if you will, for size consideration for treatment. So are there risk stratification scores that we can use? And the answer is yes. So the phases score came about from a derived pool analysis of 6 cohort studies that totaled over 8,000 patients. And amongst those over 8,000 patients, they had 230 patients rupture over the course of what was estimated to be over 29,000 person years, if you will, of observation. So that the 1-year rupture risk was estimated to be overall about 1.4%. Again, same vicinity as our previous studies. But they did more than that. They looked at risk factors and tried to build a stratification score. And so they looked at a patient's background, noting that particularly in Japanese and Norwegian and Finnish populations, there was an elevated risk. They looked at hypertension, age, size of the aneurysm, again, incorporating Ishua, and then prior subarachnoid hemorrhage and the site. And based on that, patients were graded, and then the 5-year rupture risk was calculated. So for example, if you have a patient with a score of 7, their 5-year risk of rupture would be 2.4%. So It's very important, though, to have the other side of the equation, which is the risk versus benefit. What is the complication risk? So if you have a complication risk of your procedure of 2%, then you really need a score of 7 in order for those to equal out at 5 years. So it's important to have that other side, if you will, of the equation, know your complication rates. So when you look at phases, though, there are some shortcomings. Well, it does account for size and location, and it adds things like patient's background, age, and hemorrhage. It's still missing some factors that we know from prior studies are related to risk. And so smoking is glaringly absent from the issue, from ISHUA and from phases, as well as family history and comorbid conditions. So that's where something like the UIATS score came into being. And so this was a score that was developed to be a consensus for treatment, essentially providing you, the provider, a sense of what would others do with this aneurysm? Would they treat it or not treat it? It was based on an international multidisciplinary group of about 69 specialists, and they analyzed 30 different cases using a Delphi technique. And from this, they created this scoring system. So you've got things like age, prior risk factors for the aneurysm, clinical symptoms, life expectancy, comorbid conditions, size, morphology, location, and several other factors that could be calculated in order to provide a sense of what to do. So it doesn't have any prospective rupture risk validation, though. This was really a consensus statement rather than a prospectively collected evaluation that looked at number of patients that ruptured over time. So beyond that, what else do we have? We have following patients for growth. So if you have a small aneurysm that you've determined is low risk, you might want to watch it. And I would recommend doing so because in studies where they found serial growth on imaging, the risk of rupture goes up significantly. So for example, in a study of over 1,000 patients, they followed the patients for 1.5 times growth. And the annual rupture risk, if there was positive growth, was about 18.5% per person year. And so this is an important concept because growth indicates an unstable situation and would prompt us to consider treatment. In addition, there was a study in 2016 that looked at small aneurysms and looked at the probability of growth, noting that the probability was very small, but when they did grow, the risk of rupture went up significantly. Another important new frontier is looking at vessel wall imaging. And this is a study, for example, that looked at gadolinium-enhanced MRI scans, looking at the vessel wall to see if it enhanced. For patients with no enhancement, there were 0 ruptures, whereas with patients who had notable enhancement, they ended up rupturing in 4 out of 19 cases. Now, granted, this is a smaller N, but that's a significant difference, obviously. So how do we use all these? How do you incorporate them into your practice? And the answer is just be consistent. So in my practice, I don't usually use ISHUA because I find it to be relatively inadequate. Rather, we calculate a phases score and a UIAT score for every patient and note those risk predictions in our documentation and assessment and plan. But that, again, going back to the fact that this is only one side of the coin, you have to look at your treatment risks. So look at these different options. These are the different tools we have now for treatment of aneurysms. Simple coiling, stent coiling, endoluminal flow diversion, intrasaccular flow diversion, clipping, trapping, bypass, and ask yourself, what are the risks of each of these in your hands? So the importance here is to not do any harm, right? So we want to self-assess, track your outcomes and complications, You can use institutional databases, multi-center databases, peer review. And you can also use PSOs and national databases such as NVQI QOD and Get With The Guidelines data. So these can be important, not just for an institution, but for you to keep track of your own complications. And constantly be on the lookout for self-improvement. Use courses, meetings, talking with colleagues when you have a difficult case. Use those opportunities to continually improve and to reduce your complication risk. So you have to be open to self-retraining, as I call it. So this is the concept that, our field is changing. When I started my practice, we didn't have intrasaccular flow diversion. We were just getting going with endoluminal flow diversion. And so you have to be willing to learn new stuff. But with that comes a responsibility to incorporate it into your practice in a way that's safe. So in the last few years, I have transitioned primarily from femoral access to radial access for my interventions, but I didn't simply jump into it. These were the steps that I took to transition to radial access. So I attended a national meeting and heard some talks about it. I watched 2 different webinars about the techniques. I called a colleague who I knew was a high volume user and got their protocols, got their cocktail protocols for infusing drugs to keep the vessels open and prevent vasospasm, and got their protocols for closure. We revised our hospital protocol. We educated our staff. So the people around you are so important in helping you when you're in the operating room or in the angio suite. Educate them, okay? Then I started with simple things. I forced myself to do 50 diagnostic angiograms first before trying any interventions. And I analyzed them. I asked myself what worked, what didn't. And then I started interventions, but I chose not to do any stroke cases because I felt those were time sensitive. We didn't want to be struggling to get access on a stroke case. And then finally, I added in the stroke cases, and now we're over 95% radial access or upper extremity access, if you will. So I'm going to stop there, and here's my email. I'm happy to take questions from you. Feel free to email with any questions or any comments. And if I can help you in any way with these topics in any other way, let me know. Again, thank you so much to the CNS Education Committee, and I hope you have a good day. Thank you.